Good morning, everybody. Good afternoon to those on the East Coast. Welcome. My name is Sarah Dash. I am President and CEO of the Alliance for Health Policy, and I am thrilled to be your moderator today. It's my pleasure to welcome you on behalf of UC Irvine's Center for Healthcare Management and Policy to day 2 of the 31st Annual Healthcare Forecast Conference. Thank you all for joining us this morning, and a special thank you to the conference sponsors who made it possible for us to be here today. A few housekeeping notes before we begin. Audio is muted for all attendees. You can submit your questions using the Q&A function in the Zoom webinar. Please do not use the chat to submit your questions, but you can use the Q&A function. Your speaker presentations will be available to view and download from the Whova conference app, and the link for the recording will be emailed to you after the conference. If you would like to earn physician CMEs, you must fill out the survey that will be emailed to you on Friday, the day after the conference. So now to introduce today's session. More than 20 years since the seminal report, Unequal Treatment, was published by the National Academies Institute of Medicine and extensively documented the effects of longstanding and present-day systemic racism on healthcare treatment and outcomes, we can unfortunately and unequivocally say that major disparities in access to healthcare, care delivery, and outcomes still exist. And our topic today is focused on specifically how the healthcare delivery system is transforming towards a future where health equity is indeed a reality. So to begin our conversation today, I am honored to introduce none other than Dr. Meena Seshamani, who is Deputy Administrator and Director of the Center for Medicare at the Centers for Medicare and Medicaid Services. You have her extensive bio in your conference app, and she really needs no introduction, but I will just say Dr. Seshamani is an otolaryngologist. She's an accomplished strategic leader. She has been, she's going to tell us a little bit more about her journey today. Welcome, Dr. Seshamani. It's great to see you.
Thank you so much for having me.
Great. And we're going to have about a 25-minute fireside chat here. And I, again, encourage folks to submit your questions in the Q&A, and we will weave those in throughout this next hour. So Dr. Seshamani, will you tell us about your journey from being a physician to a public servant, to overseeing healthcare delivery for a very large healthcare system, to your current role, really directing the Medicare program? Are there any common threads that stand out for you personally that illustrate the intersection of care delivery and health equity and that shape your thinking on this issue?
Yeah, absolutely. And again, thank you, Sarah, and to UC Irvine for inviting me to join you again this year. It's great to be back. And it's an honor to lead Medicare during this pivotal time in our nation's health. You know, as all of you know, Medicare is the bedrock of our nation's healthcare system. More than 63 million Americans are enrolled in Medicare, and it accounts for 1 out of every 5 healthcare dollars. So when you make a change in Medicare, it really wields influence on the healthcare system writ large. And that's an opportunity and a responsibility that I take very seriously. So, you know, Sarah, you had mentioned about my experiences and my journey, you know, being a practicing physician, working in a health system. You know, definitely as a doctor, I experienced firsthand the enormous difference that Medicare has made for my patients. And in my care transformation leadership role at MedStar Health, I understand the tremendous opportunities that Medicare's quality and payment programs can have to bring health sectors together in partnership to truly advance health in our nation. So one example of this, one of the programs that I led when I was leading care transformation in a health system was community health. And I want to share just one example of the power of care transformation to profoundly impact the health of people we serve. We had a woman with chronic obstructive pulmonary disease who kept getting readmitted to the hospital with breathing difficulties. We paired a community health worker with her who went to her house and discovered that her power kept getting shut off, preventing her from using her nebulizer. So the community health worker helped to resolve her lack of electricity and the woman stayed healthy and was not readmitted to the hospital. So this example has reinforced to me the firsthand the impact on patients, their families, and their communities when the system doesn't work for them, and the tremendous and lasting benefit when it does. So I am truly committed to ensuring that we improve care for all of the people we serve and that we keep them at the center of what we do. So I bring all of these past experiences to bear when thinking with our team about our vision for Medicare. And this vision aligns with the overall vision for CMS to advance health equity, to expand access to affordable coverage and care, to drive high quality person-centered care, and to promote affordability and the sustainability of the Medicare program. So if I may, I'd like to kind of walk through this a little bit with all of you. And first and foremost is advancing health equity, which I know brings us all here today. We must look at everything we do through the lens of health equity, because when the system doesn't work, it's those individuals with complex health and social needs who fall through the cracks. Again, I know this personally as a physician, where I've had first-hand experience working with people who don't speak English, who don't have a family member who can make multiple phone calls and follow up on paperwork for them, and who get lost in the shuffle. So recently, for example, we announced a proposal to ensure that materials developed for people with Medicare are easy to understand and available in more languages. Along this same line, advancing health equity requires building the capacity of healthcare organizations and the workforce to reduce disparities. So following congressional action, we announced that we're funding more medical residency positions in hospitals serving rural and underserved communities, one of the largest increases in partially funded residency slots in a decade. Now, having providers train in the very communities that need them most means that these providers will be better equipped to treat these disadvantaged communities. And these providers will also be more likely to practice there after finishing their training, meaning that these communities will benefit for years to come. Now, while equity is one of the pillars of our vision, it's important to remember that equity also drives and it underlies each and every pillar of our vision. So for example, we want to drive high quality person-centered care, aligning and growing holistic care models with the goal of having 100% of people with original Medicare in a care relationship with accountability for quality and the total cost of care by 2030. Now that has a direct impact on equity, because when providers work together to address a person's needs across the spectrum of their experiences, you can address fundamental disparities that have impacted health. Another example, another pillar of our vision is to improve access to coverage and care. We're prioritizing increasing enrollment in the Medicare Savings Program, which provides financial support for those of lower income and resources. Now, 10.3 million people are enrolled in these programs as of December 2021, and that's a more than 800,000 increase from the prior year. For 2022, we will continue to make it easier for people to enroll in Medicare, eliminate any delays in coverage, and make sure that they can afford care. And finally, another pillar in our vision, we want to be responsible stewards of the Medicare program. We are increasing transparency regarding hospital prices and also how Medicare dollars are spent in Medicare Advantage. And we'll continue to improve payment accuracy to address fraud, waste, and abuse. But again, circling back to where we started on my journey as a provider, leading healthcare transformation, working as a policymaker, being a health economist, if there's anything I've learned through all of this, is that all of this work has a common theme. We have to all work together. Now that I'm at CMS leading Medicare, we must work with all of you. We must work with all of our partners so that we can together put people with Medicare at the center of all that we do. So we really want to hear your ideas, and we want to work together to be able to drive meaningful change in the healthcare system.
Thank you so much, Dr. Seshamani, for that overview. And indeed, that example with the community health worker and the woman's power being turned off, it's just one of so many examples where the healthcare system is put in is really left to care for people who have, as we've called for a long time, social determinants of health, and there's having one's power turned off and not being able to care for oneself. That's a social determinant of health. But it took that care delivery transformation effort, obviously, to take care of that one particular patient. We've heard so much, and of course, we'd be remiss not to talk about. We've heard so much about the COVID-19 pandemic and its impact, and the way that it's brought to light so many health disparities. What, from your perspective in the Medicare program, has changed, if anything, in terms of dealing with COVID-19, the impacts, and what do you think, if anything, the lasting impact will be on the way that the Medicare program operates?
Yeah, I don't think we can understate the extent to which COVID has changed the context in which all of us are operating. The pandemic has really moved the ball forward on a number of conversations that are directly connected to the vision for Medicare that, I was talking about with you. For example, the pandemic has made concepts like health disparities, health inequities, and social determinants of health. We've been having these concepts and had these conversations in the healthcare world, and they have now become household phrases. The profound health inequities have persisted in our nation for generations, and many of these inequities have been laid bare by a pandemic that disproportionately and adversely affected people who are Black, Hispanic, American Indian, Alaska Native, people with disabilities, the elderly. And so really the pandemic has brought that to the fore to enable that conversation, to enable that innovation and movement. Similarly, we're talking about behavioral health. We're talking about social isolation more than we ever have before. And we're talking about how to deliver care where people need it most. And we're doing that more than we ever have before. The pandemic has accelerated innovations in both telehealth and care in the home. It's highlighted the need to strengthen behavioral health. And these are things that we are taking to heart, and we want to harness these lessons learned as we move forward with the Medicare program. And, so just one example of this, we have expanded access to telehealth services for beneficiaries with behavioral health needs for even after the pandemic. And again, coming back to my experiences as a physician and leading care transformation on the ground, I know that enabling someone to engage from their home, who previously may have had to take multiple buses to get to a clinic, can make an extraordinary difference in their ability to access healthcare and their quality of life. And so really being able to think about all of those ways that the pandemic has brought some of these issues to the forefront, has driven innovation, and where we can harness those lessons learned moving forward.
Thank you. Thank you so much. And I want to certainly get to some of our additional questions here, but since there's already a few questions in the Q&A, and one of them pertains to something you mentioned, I don't know if this is something you can answer, and I realize that it's a very complicated question, but Dr. Pitts was asking if telemedicine will continue to be authorized going forward. And I wonder if, just for the sake of the audience, if you could share a little bit about what may be the deliberation process there. As you mentioned, telemedicine, certainly for behavioral health, but we know obviously for other populations as well.
Yeah, absolutely. And not just with telehealth, but with all innovations that have been occurring, we really will be evaluating them against those strategic pillars that I mentioned. Do they advance equity? Do they drive high quality person-centered care? Do they promote affordability and sustainability of the Medicare program? So I think overall, as we think about ways that we want to drive meaningful change in the health system, really thinking about how they measure against those areas that we really want to make sure that we're driving the needle forward. Specifically with telehealth, anything that we can look at, we have to look at through a lens of what is possible in the Medicare statute, so in the legislation, are these things that we are able to do, and then look administratively to where there are opportunities to do so. And so telehealth is an example where, there are things that could be done administratively. There are things that, may require changes in statute. And so those are some, ongoing conversations that I know many stakeholders are involved in.
Right, absolutely. Thank you. Well, so speaking of that, you laid out the vision for CMS as a whole, and you talked about your strategic vision for Medicare. In late 2021, CMS released an update on its overall health equity plan, which was really like a 5-year continuation. As I understand it, it was an update of something that had previously been released. And there are 6 priorities outlined in there. Would you walk us through kind of where do you see the core efforts being made there, and where do you think the most progress has been made so far?
Absolutely. And a lot of this comes back to what we were discussing a little bit earlier about how CMS can really, broadly wield influence and provide guidance for the healthcare system writ large. So to start with, for Medicare and for CMS more broadly, what does health equity mean? So for us, health equity means the attainment of the highest level of health for all people, where everyone has a fair and just opportunity to attain their optimal health, regardless of race, ethnicity, disability, sexual orientation, gender identity, socioeconomic status, geography, preferred language, or other factors that can affect access to care and health outcomes. So moving from that of how we think about health equity, how do we then try to advance that goal? And there are a few principles that we have, or buckets of work that we have in this regard. So one is expanding the collection, reporting, and analysis of standardized data. I like to say that you can't improve what you don't measure. And I think we all know that there are substantial opportunities for improvement in this regard. And one example of work that we are doing here, we have out for public comment, being able to collect optionally demographic data when people enroll in Medicare Advantage or a Part D prescription drug plan. Another pillar here is being able to evaluate the impact of disparities and look to equity solutions that we can integrate across our programs. So to give you a recent example on this from Medicare, in our Medicare Advantage Advance Notice, we are seeking comment on a potential health equity index, a measure for Medicare Advantage star ratings that would take into account how well plans are advancing health equity, and being able to think along those lines, not just in Medicare Advantage, but also how are we thinking about, our hospital readmissions program? How are we thinking about our innovation center models? How are we thinking about our accountable care organizations to really have that alignment and driving towards, that health equity advancement? Another priority that we have in our equity plan is building the capacity of healthcare organizations and the workforce. Now, this includes practitioners from communities of color and people who are primarily serving communities of color, so that we can reduce health and healthcare disparities. And so here, circling back to something I touched on earlier, we are increasing Medicare-funded residency positions in underserved and rural areas because we feel this is an important aspect of being able to advance equity, is really building that capacity for the healthcare system in those areas. And then the final, pillar that I'll speak to here is being able to improve access for everyone, including individuals with limited English proficiency or persons with disabilities. Now, I mentioned earlier, I speak Spanish fluently, and, so I have experience serving people as a physician who don't speak English. And when people do not understand what their providers are telling them, they can get left behind. And so, this is why, again, we are proposing regulations, for example, with Medicare Advantage, to ensure that materials that are developed for people with Medicare are easy to understand and available in more languages. And we want to do more here as well to make sure that care is culturally and language accessible for everyone.
Thank you. Thank you so much for outlining those pillars. And of course, for anybody who's interested, that is available online, the CMS Health Equity Plan with extensive detail. I want to circle back to something you mentioned because there is a question from the audience with regard to the GME funding for residency training. And the question is, what evidence is there that residents who train at rural and underserved hospitals remain there after graduation to ultimately care for those who are served by those hospitals and presumably the healthcare system around them? And is that something you can speak to? Obviously, there's also other healthcare programs out there, funded through other titles that also sort of have a service requirement. Is that something you can speak to?
Yeah, I mean, and you're right. It's not just for this particular program, but in general, research has found that where people train, they are likely to stay. I mean, we can follow up with specific papers, et cetera, but there definitely is a body of research on this. And to the point that you made, Sarah, this is also something that has been evidenced through the National Health Service Corps, for example, where people are more likely to stay even after they finish their service requirement. So that is definitely something that we took into consideration as we were coming up with this policy.
Great, thank you so much. So I would love for you to have a chance to speak directly to the beneficiaries. That you mentioned a little bit earlier, kind of the role of social isolation and behavioral health, particularly for older adults and persons with disabilities and sort of the population that the Medicare program specifically serves. What does success look like for those beneficiaries, and how are you going to measure that?
Yeah, well, Medicare has a vast network, more than 1 million clinicians and 6,000 hospitals. And so I feel very strongly that Medicare can serve a catalyzing role in addressing inequities, and to do so in a way that can really, support the lived experiences of people with Medicare and the providers who care for them. And so, how I think about this in the vision for how we advance equity in Medicare, it's really twofold. First, improving operations overall, and second, implementing specific policies that advance equity. So for example, on improving operations, it's really about making sure that care is reliable, it's easy to navigate, it's high quality, and it's comprehensive. And in doing so overall, this will particularly support those who may not otherwise have the resources or the ability to advocate for themselves. So we really are trying to very thoughtfully engage stakeholders whose voices are not always heard in efforts to improve care. We are committed to partnering with the entities that we work with, from providers to plans, and also working with people with Medicare to make sure that equity is at the forefront of all of our operations across the system. And a more specific example of this that I want to come back to, I mentioned earlier, we're prioritizing enrollment in the Medicare Savings Program. So this program is essential to help millions of people with Medicare be able to access care. It provides financial support for low-income beneficiaries. Yet only about half of those people who are eligible for the program were enrolled. So it's important that through our everyday operations, we are engaging people, we are explaining to them what different options are, and we are incorporating feedback from them to make sure that what we're doing makes sense and works for them. And so that's why, as I mentioned, we've increased enrollment in this program by 800,000, and our work is not done. We are continuing to think about ways that we can make sure that the work we are doing is actually reaching people and is actually helping people and serving people in the way that we all want and the way that they would want. So, another example of this is the behavioral health, telehealth, right? Thinking about the ways that we can make sure that we are addressing some gaps in ways that people can experience. And so I mentioned the behavioral health. Another example, we recently approved for the first time an enhanced payment for an easy to use home dialysis technology. We know that people with Medicare in historically underserved and under-resourced communities have higher rates of end-stage renal disease. And so it was important for us that there is home dialysis technology that's easy to use for people who may not have the resources or the supports otherwise to be able to stay in their home. And how much, again, coming back to the theme of the COVID-19 pandemic, how much that is valued now, where people want to be able to have care where they most need it, where they're most comfortable, and where they can be safe. And, I think the final example I would give is that partnership that we need. And I really want people with Medicare to see that partnership, to see that people are working together to care for them across all of the experiences that impact their health. So, we recently proposed that all Medicare Advantage special needs plans screen for housing instability, food insecurity, and transportation. So that again, these health-related social needs are being brought to light, particularly for communities who are struggling with poverty, that we are encouraging providers to take this more holistic approach to promote equity and fully address the needs of the communities that they're serving. And we want people with Medicare to see that.
Thank you so much. That's really helpful, and those specific examples are really helpful. And if I could to follow up on a couple of them a little bit more specifically. So I would love to hear your thoughts on, as let's say for the Medicare Advantage special needs plans, you say you propose that they screen, right? And one of the conversations has been what can they then do, right? Like where is the limit? And how does if you sort of bring the flashlight up even more, right? How do you envision, and is Medicare working with other segments of the federal government or others at CMS to sort of help to foster more of that more holistic approach where, let's say there is something that, through the screening, they find unstable housing or something like that. Like what happens then?
Yeah, and I think that's an excellent point. And I think this comes back to, one of the things I mentioned with our health equity strategy around improving the capacity of healthcare organizations to address disparities and advance equity. Where we have an opportunity to have our learning collaboratives, to be able to facilitate partnerships, to be able to see where there are grant opportunities that, can be paired for providers, community-based organizations to be working together. There's definitely more work to be done in that regard. And that is a direction that I think all of us want to move in.
You mentioned, for example, the special needs of communities of color in particular as it relates to end-stage renal disease. There's another question in the audience with regard to sickle cell. And, the specific question is, can you include patients with sickle cell among the underserved community? Can you speak to some of those dynamics? Like, what do we know about the population of individuals who have sickle cell disease, and how many of them are is this more focused for the Medicaid program as opposed to the Medicare program? What are your thoughts there?
Yeah, and the way that I approach this is that there are chronic conditions that are more likely to impact certain populations and that require a more holistic approach so that we can best support people who have these conditions. And how do we make sure that we are setting the system up in a way so that those issues are being addressed? And, a good example is with our accountable care organizations, right? Where we have groups of providers who we bring together to improve quality and spend the Medicare dollar in a smarter way. And where there are opportunities there to create those partnerships, provide that input so that that care can be provided in a more coordinated fashion, looking across the various aspects of care that are needed that may not occur in just one episodic visit. I think that is a theme that applies to end-stage renal disease, to sickle cell, to the woman who had chronic obstructive pulmonary disease that I mentioned earlier. So that is a common theme, I think, for how we would want to approach these kinds of issues so that we can make sure that, again, we are striving towards that goal of health equity that I mentioned earlier, that everybody has the opportunity to achieve their optimal health.
Thank you. Thank you so much for that. And so there's a question here around direct contracting. I know you mentioned some of the models already, the ACOs and so on. We know direct contracting is one of the models. We know that this is a very live debate right now. So I don't know if that's something you're able to comment on, but the questioner asked what's going to happen on that or not. And maybe again, just for those, again, I know this is something that a lot of folks are following, but maybe for those who are in the audience who maybe haven't been following it so closely, is that something you're able to offer a brief explanation and share your thoughts on, again, where sort of the deliberations may be?
Yeah, taking a step back, last August, I think, the CMS leadership had put out a blog in Health Affairs outlining the vision and the strategy for innovation in CMS writ large. And key to that, there was a thread that I pulled in doing the vision for Medicare specifically, and that is having alignment across our centers where, if there is something that the Innovation Center is testing in a model, if there is a lesson learned, does it work, does it not work? How does that then get incorporated into the Medicare program writ large? And in the flip side, are there things that we see in the Medicare program that it would be really good to see if making a change could make a difference? And, having the Innovation Center then test that. And the other piece of it is having that alignment where, there is work across fee-for-service Medicare, these care models in original Medicare, and also Medicare Advantage, where we can have better alignment across these programs to really be able to drive meaningful change. Because again, as a provider, I know that when you have 50 different ways of doing things, it can become confusing for providers, for the patient or people with Medicare. And so really being able to have more of that alignment, not just across programs within Medicare, but across multiple payers, to be able to really, drive that transformation.
Yeah, thank you. Thank you for that. And again, let me encourage folks to go ahead and share your questions in the Q&A. We're now, I didn't say it, but we've officially switched to the audience Q&A session of this conversation. So go ahead and keep those questions coming. And thank you so much for reminding us of that health affairs piece, and that maybe that is something that we can share with participants or send out in the chat as well. So great. There was a technical clarifying question regarding the ESRD home dialysis programs. And the question there is whether that would include both home HD and PD. That might be a very specific question. Is that something that you're able to answer here? Or is that something we can get back to our questioner about?
So what that policy was, it created an add-on payment for a new technology that allows for home dialysis.
Okay, thank you very much. That's great. On that point of sort of additional payments, there is a question here about whether you could kindly comment on the problem of approval of innovative devices that can make a significant impact. Is having a robust approval pathway part of your vision for the agency?
Yeah, this actually comes back to something that I mentioned earlier with the question on telehealth. I think overall, the approach is looking at these innovations on, do they advance health equity? Do they expand access to coverage and care? Do they drive high quality person-centered care? And do they promote affordability and sustainability of the program? And that is the way that we will evaluate all of these innovations.
Great, thank you so much. And Sorry, I'm just getting my questions organized here. I want to thank Dr. Pitts who put in the Q&A a response to the earlier question, by the way, about folks staying in the areas where they trained, and mentioned a study there about 80% success rate. So thank you. And he has another question. And you had mentioned really this topic of, Medicare being a good steward of the resources. We know certainly that Medicare affordability and solvency is a question that comes up. The questioner asks if you have any thought about the Medicare response to inflation in the U.S. Obviously, we know consumer price index inflation, healthcare inflation can be somewhat different. Can you share your thoughts as to how is Medicare looking at kind of keeping costs down or cost growth down? And again, since we are focused on care transformation to advance health equity, like how do you see those two paths intersecting or not?
Yeah, I mean, I think it comes back to the example that I gave of the woman with chronic obstructive pulmonary disease, right? Like if she kept coming into the hospital like 17 times, each time she comes in, she has this copayment, out-of-pocket cost that she has to pay. By fixing her electricity problem, she no longer had to pay that out of pocket. And I think where we have the opportunity to transform care to advance health also presents an opportunity to make sure that care stays affordable for people, that when we coordinate care and we make sure that they're on the right medications that they need to be on, or that you're not duplicating, labs or images, and that you're making sure that what you're doing is really as effective as possible, that will promote affordability for people with Medicare. The other point that I'll make, we did also propose recently, I mentioned transparency as something that is very important in this pillar. So there's the hospital price transparency work. My colleagues in CMS also are working on the No Surprises Act. Another aspect of this is transparency in the drug space. And we recently proposed, where there are pharmacy price concessions, to have more transparency with that, where the pharmacy price concessions are brought to the point of sale. What that does is it increases transparency about what is happening in that space. And also it brings any savings from those price concessions to the point of sale for the beneficiary, so that the person with Medicare who's going to pick up a prescription benefits from those savings when they pick up that prescription. So that's like another example of where there are opportunities for us to make sure the program is affordable.
Thank you. That's really helpful. And I want to circle back on that affordability point. I mean, that's a pretty spectacular increase, it seems, in the number of people that you said are enrolled in the Medicare Savings Program, or I believe you're going to correct me if I'm wrong, but the Medicare Extra Help kinds of programs. I'm curious if you could share a little bit more detail on how you accomplish that, and what do you anticipate going forward? Like, do you think that those gains will remain? What are you looking forward to as the next step?
Well, I think that is the Medicare Savings Program is one example of how I think we need to make the program easier to understand and navigate. So during Medicare open enrollment, I did a series of virtual, media tours, doing interviews for radio, TV, on what is Medicare, what are different options that are available. And I drove home at every single one of those. If your income in 2021 is low, here is the place to call to be able to find out if you could be eligible for this program. I think broadly, really trying to engage with people so that they understand what options are available. And on our end, looking at Medicare.gov, 1-800-Medicare, our plan finder, to make sure that the options that are out there are easy for people to understand and navigate so that they can pick what works best for them. So that is part of a larger effort that we have.
Thanks. That's very, very helpful. Okay, so we still have a little bit of time. So again, we'll have time for probably a couple more questions. So if folks want to submit them in the Q&A, we can do that. There was a question that's been waiting for a while, so I wanted to ask and make sure we got to it. you know, and you can kind of take a look at this, but there was, as you know, there was a session yesterday on sort of how politics will impact healthcare delivery. The questioner mentions that Texas is currently debating policy to make gender reassignment surgery a form of child abuse and illegal. You know, that's according to the questioner. The question is how can Medicare use its influence to advance health equity from state to state? And I wonder again if since Medicare is a federal program, you know, if you can comment on maybe how you see the Medicaid program and intersections there, right? Like how are you looking at ensuring that that we have an equitable healthcare system from state to state, and of course not asking you to comment specifically on the Texas law per se, but how do you view that? Like, you know, are you looking together at state by state data, you know, geographic data on disparities? Share your thoughts.
So Medicare is a federal program, so you know, we do look at geography. I think that is a key component of where we need to look at where there are disparities and try to address. That is something that is, you know, in, you know, what I described for what health equity means to all of us who are working on this. You know, one example is with our accountable care organizations, you know, looking at where we have involvement in some of these care models that we've been talking about that can really move care upstream to address health-related social needs, to have better care coordination, more person-centered care. Are there certain providers, areas of the country that aren't as engaged? And can we do more there? Like, can we support with investments in infrastructure for smaller providers or providers who are caring for underserved populations? Is there more that we can do to engage with people, with Medicare, with providers, payers in those areas that you know, there hasn't been as much take up, to see why is that? What could we do to help reduce barriers? What could we do, again, coming back to the theme of really working together so that we can advance health equity and we can drive person-centered care? I mean, that's an example of how we are thinking about the ways for partnership and thinking about disparities that occur across the country by geography.
Great, thank you. And there was a related question here about CMMI, the Center for Medicare Medicaid Innovation. I believe the sort of intention of the question is around what type of CMMI initiatives are addressing that sort of state to state piece. Can you maybe just share, obviously, kind of like where can people keep track of what is happening and isn't happening in terms of, as you mentioned, like the many models that that have been tried across Medicare and Medicaid, and you know, share a little bit more about what kind of updates you maybe imagine might occur. I know there was recently separately a vision sort of laid out for CMMI, and there's a white paper out. So is that the best place to look for people who are curious to find out more information?
That's right. There's a CMMI white paper that was put out last fall that speaks to how equity is at the center of all of the models they develop. They want to streamline their models. So I think that's a good resource. The other is, you know, as we started off the conversation, Sarah, with the vision for Medicare across those pillars of equity and driving person-centered care, you know, I put out with Liz Fowler at CMMI and our administrator, Chiquita Brooks-LaSure, in Health Affairs at the end of January, you know, kind of how the innovation work plays into how we want to make sure the Medicare program writ large is addressing health equity and is driving this innovation and promoting the affordability and sustainability of the program. So that's the other place that I would suggest.
That's great, thank you. And I believe we have that link, and we're going to try to send that out to the attendees for those who may have missed it. This is great, and we just have a few more minutes, so I want to just first again thank you for spending so much time with us, and ask you, you know, before I sort of get to my final question, is there anything else that I've missed? when you close out your term at the helm of Medicare, I feel like you just started, but how do you think you're going to measure your success? And is there anything else that you want to say to us here today?
I mean, I think how I would measure my success and how I would measure the success of the Medicare program is really, have we moved the needle on the things that we're talking about today? Have we made care more person-centered? Have we been able to address some of the disparities that have plagued our healthcare system? And have we supported those in the community, all of you who we're talking with today, to be able to take better care of, people with Medicare and even beyond? I think that's really what my goal is. And that's what, being a practicing physician, working in a leadership position in a provider organization, understanding, the details of the health economics, of our system, that's what I really hope to bring to bear with all of those varied experiences.
Great, thank you. Well, you mentioned that you are soliciting comments on a few proposals, including a health equity index for the STARS program. There are a couple of other comment periods open. Can you share a little bit more there about, are there specific things that you're looking for comment on? And then leading into really sort of a final question here, which is, you spoke to the strategic pillars around partnerships, really engaging patients and beneficiaries and stakeholders. We obviously have an amazing audience here today, even though unfortunately we can't see them, but we know you're out there. We have clinicians in the audience, business leaders, healthcare executives from across the healthcare spectrum, and from states and the nonprofit sector as well. So I would ask, in sort of combination, what do you need from the stakeholder community? What are you looking for? What do you need from your partners in order to help Medicare meet its health equity goals?
Yeah, well, everything that we've talked about today really does have the common theme that we have to work together to put people with Medicare at the center of all that we do, and that we are never going to achieve our broader goals if we're all thinking about the problems and trying to find solutions by ourselves. The only way we can do it is by partnering across the various healthcare sectors that touch a person's life, so that all parts of the healthcare system are rowing in the same direction. And so to that end, answering comment solicitations, engaging, letting us know if you have ideas, and also thinking about how in your everyday, just as how, I mentioned that we think about equity, and I personally think about equity in every single operational decision and every single policy decision that we are making. How are all of you doing that as well? Because there are levers that we have in CMS, and there is work that plays out on the ground, on the front line, and where there are opportunities to forge those partnerships, where there are opportunities to bring healthcare providers together with community-based organizations, where we can really leverage, that example of the community health worker. Yeah. There are tremendous opportunities, not just for us in CMS, but for all of you and for all of us working together to think about where we can innovate, where we can forge the partnerships, where we can coordinate care, where we can provide better data, so that we really are connecting the dots, so that we are taking care of people as people, and not just as somebody who comes in with a specific diagnostic code or specific procedure code for a specific episode.
Yeah, absolutely. Thank you. And certainly farther along on that journey than we were even 10 years ago. So again, thank you so much for being with us. It's been a real honor to speak with you today, and for all the work that you are doing. And I'll give you the final word if there's anything else you want to say in closing. But again, Dr. Seshamani, thank you so much. You've really outlined a lot in terms of your vision, your shared vision across CMS and CMMI, your efforts to increase affordability, just plain pocketbook issues for beneficiaries as a health equity measure delivery system reforms in terms of things like the home care for dialysis and the community health worker, and of course, all of the various programs that you have across the board. So you've outlined a really broad agenda. I'm sure you've got a busy day ahead of you. But I'll ask you if there's any sort of anything you want to say in closing, and then we'll pause and go to our panel.
Well, I just want to say thank you for having me, because I really think this is the way that we can work together. I mean, see this as a call to action. What are my final words? A call to action that, with this vision that I hope makes sense, that we can share, that we can work on together, that we can really make a difference for all of the people who we serve. Great.
Thank you so much, Dr. Seshamani, for joining us and for being with us. And of course, for folks who want to read further, there's lots of additional reading material. It's almost the weekend, so buckle up. We got the CMS vision, the white paper, and so on. So thank you again. Appreciate your time today, and have a great afternoon.